I consider myself as a clinical informatician. My kind of journey in that space really began when I finished medical school, and actually just down the road, actually, Barton in London is my alma mater. So once I finished medical school, I went into foundation training. And as a foundation trainee doctor in Bedford Hospital, I quickly realized that we were using certain tools. So one of those tools that we were using was something called the hospital at night system. And the idea behind the hospital at night system is something that you carry around that helps to tell you what jobs you need to do in terms of urgency or priority. And the thinking behind it was, if you have this wonderful hospital at night system on your device, you won't get bleeped so much to try and call you to do urgent tasks. And in theory, it was an excellent idea. What practically happened is the device that we carried around also made loads of noise. And every time you were sent an urgent task on that device, it bleeped and constantly bleeped. And unfortunately, there were certain nights where we were sent urgent tasks for things that were perhaps not urgent. So things like prescribing a patient paracetamol overnight was sent through as an urgent task. And along with a few colleagues, we really saw this as an issue because it wasn't really making our workload easier. It was actually making it very difficult to manage. And so we did a piece of work where we linked up with someone called the Guardian for Safe Working, who was kind of responsible for supporting junior doctors in the organisation, as well as the IT team at the time, to really think about the data that's coming through that system, how the tasks are prioritised in terms of urgency, and how we can go and look at that data and what we need to do to try and make that system work a little bit better. And to be honest, a lot of it was thinking about the education and training of nurses, of coordinators, of some of the people that were sending those tasks through, and then trying to demonstrate the urgency of that task and creating a bit of a protocol for them to manage that urgency better so that we weren't so overloaded. But we also came out of it with other kind of solutions. We started to think about how we distribute the workload overnight between doctors that were working in the medical part of the job versus doctors that were working in the surgical part of the job. You may or may not be surprised to hear those that were working in the surgical part of the job didn't really have as much work to do as the medical side and weren't that keen to kind of help out with the medical side. So we changed that. We said, no, we really do need to kind of think about the workload and split it between ourselves because the skills are essentially the same for those junior doctors that were working across both medicine and surgery. And ultimately that leads to better patient care. And that was for me an introduction to this space, but I can't say I knew that at the time. It was only a few years later when I was lucky enough to join Health Education England as a clinical fellow, working with Patrick on not necessarily the topical review, which was a piece of work that was done to start to understand how we prepare the NHS for the digital future, but subsequently what came out of the topical review was I started to reflect that actually this was something that I had a skill set for, that I understood a little bit better, was able to have a common language with people that were working in the IT teams and people that had those skill sets. And so how can I continue to use that to better patient care from a different point of view? And that kind of brought me into this space a little bit more. And I'm quite fortunate to have a platform to be able to build on my reflections of delivering patient care as a GP, but also then think about the wider picture in terms of how we use and improve patient care with the use of technology. And when I was approached to do this talk, I think it really hit home. It's a real nice opportunity to have a conversation about virtual health. What are the pros and cons of it? What are some of the risks, but also what are potentially some of the benefits of virtual health? And where can we go in the future with the right infrastructure, the right tools, the right culture around its use? So I was going to start by defining what virtual healthcare is, because I think the first thing to note is there are multiple definitions or terms that are used in this space. And the most common ones tend to be telehealth and telemedicine. Now, I try to do a little bit of work to try and understand whether there's any difference, and there are some that argue there is a slight difference between the two. But ultimately, I'm going to think about all of this interchangeably: telemedicine, telehealth, virtual health. Essentially, what it is it's delivering healthcare from a distance. So it's about long-distance patient and clinician contact, and about having ability to provide care, advice, reminders, diagnosis, treatments from a distance to people. And it's not a new concept. It's a concept that's been around for actually a very long time. So if we look at the history of telemedicine, actually it goes back to the 19th century. And there was a situation where electrocardiographs were shared, or information or data that came out of electrocardiographs was shared at a distance between people that were working in cardiology and people that were working in general practice. And similarly, in mental health, there were lots of those situations built in so that there was a sharing of knowledge and sharing of practice and sharing of patient care across multiple areas. And that was one of the sort of starting points in terms of a CCTV link between kind of Nebraska Psychiatric Institute and Norfolk State Hospital in the States. Big organizations like NASA who had the capability would use this technology as well to kind of support their own infrastructure, their own specialists and to deliver healthcare from a distance as well. And then from the 1980s and 1990s, you started to see the impact on imaging, being able to share images at a distance, being able to send images online, being able to report on images from a distance as well. And the real acceleration from an NHS point of view really came in 2010 with the kind of the Affordable Care Act. We started to put a little bit of the impetus going forward around telehealth and telemedicine, and then particularly move forward with the NHS Long Term Plan and the Topple Review, which were published more towards 2018, 2019, which started to plan ahead for how we develop a health and care system that really uses digital as its front door and digital as its navigator. But again, I wanted to highlight, this isn't a new concept. The World Health Organization were talking about health informatics and telemedicine back in 1997. This was off the back of a G7 summit that started to look at how technology and IT could help kind of globally, with a focus on one theme, one of the themes, which was telemedicine. So immediately it was seen as an opportunity to particularly help developing countries to be able to provide healthcare for rural and distant communities, and to kind of improve access and equitability to healthcare in those areas. And in 2010, the World Health Organization produced a report which said quite clearly that telemedicine overcomes geographical barriers and increases health and access to care, again, for those specific groups. And so reflecting on that, there was a lot of impetus at that time to sort of support and help developing countries with the use of telemedicine, but it hadn't really made an impact, even though in this report, if you go and read it, it talks about the United Kingdom really being a place to lead in the use of telemedicine. It didn't really impact. It's not something that I saw a lot when I was in medical school, for example, at the time, in terms of its usage. And it's only in the most recent years that I've really come across it in my day job as a GP. And the foreshadowing really came for this from the Topple Review, as I described. So Professor Eric Topple is a director of the Scripps Institute in the United States, was asked by Secretary of State to come and support the NHS in terms of thinking about delivering a healthcare workforce to the future. And Patrick was asked to lead that piece along with Eric Topple. And it became a really interesting report. It's something that I still go back to now almost every time I talk, because it really started to foreshadow what the technologies might be that might impact the health and care workforce in the future. And on top of that list, you have telemedicine. But what I find really fascinating about it is if you look at that kind of the shadowing of this infographic, you can see by 2025, we're expecting about 20% to 50% of the workforce will be impacted by telemedicine. We're now in 2023, and actually we're probably at already about 70 to 80% of the workforce using telemedicine in some way. So that demonstrates the speed that digital transformation has taken as a result of factors like the COVID-19 pandemic, and almost increases the urgency that we use these technologies safely, ethically, appropriately, because they are there right now, and they're proven to be a mechanism to help us overcome some of the societal, some of the strategic challenges that we are facing in health. So the NHS Long Term Plan was a really good report, because it highlighted what the key digital priorities are. And for me as a GP, it really started to create what we're seeing today as digital primary care. If you all go on your practice websites today, you'll most likely will find some sort of online consultation tool that allows you to access your GP in a different way that you might have access to your GP, say, a few years ago. We've also seen the tremendous impact of the NHS app during the COVID-19 pandemic, and subsequently the ability to be able to see your results at a distance. Now that in its own way uncovers some challenges as well. So I've had patients who have seen sensitive results on their NHS app before that result has been conveyed to them by a clinician, and therefore had a call on a Friday afternoon when I'm on call to say, what does this mean? What do I do? I'm really worried. And so we have to be really careful and have a strong understanding in terms of what is shared and how it is shared, and the reading with the level that it is shared at, because it's very difficult for people to decipher that information, and actually can cause more mental distress than good health. And so we have to really think about the use of some of these technologies when they're out there, and they're what would say patient facing. Others might use consumer facing. But we've also seen tremendous kind of transformation around e-prescriptions, for example. Now, when I'm in my clinic, I very rarely print off a prescription. How incredible is that? Whereas a few years ago, when I was in general practice, I'd be printing off multiple prescriptions a day. I remember you come into a clinic and you get a whole stack of prescriptions like that you have to sign off in the morning. Whereas now, it's all done virtually. So one, there's an environmental impact there because you're saving paper. Two, it's better for patients because the prescription goes directly to the pharmacy. They don't need to come and pick it up. And three, it's better for the clinician because it's much more quicker, efficient to do. You know, you've got you look at the patient records, you've got the alerts that tell you whether that's a good prescription to make or a bad prescription to make, or whether you need to spend some more time reviewing it. And so all of this is really, really great. It's really transformed the way I work. It actually makes the job far more enjoyable and actually makes the job far more efficient as well. And so it's an example of how we can harness technology to work better. And the impetus for that was the long-term plan. So I think we can reflect and be quite proud of that. The other big disruptor for me here was something called GP at Hand, or Babylon, that you may or may not remember. So I remember when I was a training doctor, I went to my training program and I spoke about Babylon and GP at Hand. And I said, how wonderful, our patients can access a GP in minutes now. They were told off for that because it wasn't quite true. But at the same time, how wonderful is it that 24/7 you can access a GP and you can hold a video consultation with a patient? And I immediately got shot down by my colleagues in the room to say, no, I would never do that. I absolutely do not want to work in that way. And I don't feel comfortable using a video tool to be able to consult with a patient. Move on about 2 or 3 years later, we're all doing it. And it's become, at some point during the pandemic, it became the norm, actually. It became, on top of using your telephone, the core way that you would connect with a patient. At the same time, reflecting on that, we've now probably come out of the worst part of the pandemic and usage has gone down. So why has that happened? Why are we not using video consultations as much as we used to? And I'm going to dive deeper into that in a little while, but I wanted to just kind of plant that seed a little bit. But regardless, and speaking to someone who's now the Chief Clinical Information Officer at Microsoft, but used to be part of the team that grew up Babylon, there is no question that regardless of the troubles they came under and some of the difficult relationships they had with the NHS, they were a disruptor, they were a pioneer, and they were perhaps the tool that really brought this to the market, really allowed us to see the opportunity for using video consultations to deliver patient care. The other large impact, I think, that we all know is the COVID-19 pandemic. And I've already reflected on being in general practice before the pandemic and then returning to general practice after the pandemic and seeing the difference in the way we consulted and the way we worked. Now, I think the important thing to note is we were open during the pandemic. I still get a lot of patients. I remember I had one patient right in front of me that said, are you guys open yet? Are you working now? And I said, well, you're in the room in front of me. We are consulting, we are open, but it's a culture shift. It requires a change in mindset that actually not everyone needs to physically be in the room to receive patient care. There are some cases where you can deliver patient care at a distance. But essentially what the pandemic meant is, for example, in general practice, the gap between face-to-face consultations and remote consulting significantly narrowed. And now to the point where I would say, if I had to look on my list on a Friday, it's about 50-50 between the two. So that's kind of where we've headed as a result of the transformation in technology. But really, is the technology that transformative? I mean, of that 50% of remote consultations, about 70 to 80% over the telephone. And the telephone is not a new technology. So it just changed. We just needed a sort of a change in mindset and how we kind of deliver some of the care that we need to. But again, I'm going to delve deeper in terms of video consulting and virtual consulting and some of the pros and cons of it. One of the big society drivers is connectivity. So this graphic from Hootsuite is really interesting because what it shows is the amount of people that have connections to broadband internationally. And if we look at Western Europe, we can see it's at 98%. So that doesn't mean that 98% of people have access to the internet, but it does mean that if you looked at all the connected devices that are out there, there's a 98% connectivity. So the important thing to note there is there's still a gap. There's going to be people that don't have connectivity, but a large proportion will have access to a device that allows them to have broadband connectivity. And really interesting is to note that some parts of Europe, like Northern Europe, were registered as having over 100% connectivity. So there's more devices than people connected to the internet, which I think is fascinating to think about how far we've come with the ability to be able to access the internet for majority of our populations. This is really interesting because it's something from Massachusetts General in America, and it's like kind of their response to the COVID-19 pandemic and how telemedicine played an impact there. And it talks about two things. It talks about one, the clinician to patient relationship and the role of synchronous and both asynchronous consulting. And then it talks about the relationship between the clinician and the clinician. So I just wanted to unpick this a little bit. So with the clinician to the patient, you've got the synchronous communication. That's either a virtual consultation between the patient and the clinician. And so what might be the benefits of a virtual consultation? Any ideas? Anyone think, well, I've already talked about in terms of there might be benefits in terms of being able to, someone not having to come into the clinic room or someone not having to travel. But from a clinician perspective, seeing someone behind a camera, can you think of any benefits that you think would come out of that?
They don't spread all their germs to you, the doctor.
That's true, absolutely. I mean, it does keep me a lot healthier than I used to be. Having worked in paediatrics, you almost had a cold every week, so it can be helpful.
Well, if there's a physical ailment, then obviously it's better to see that sort of not in person, but sort of if it's something that needs looking at, I don't know, if it was a mole or something that you are concerned about, then obviously that's better than just getting a description over the phone.
Yeah, and that's really key. Is where is it? What are the limitations of the telephone, and where can a video help? But actually, sometimes it's not a video you need. Sometimes it's a photo, and a photo has higher resolution. So actually, when it comes to things like moles or skin lesions, I prefer to get a photo than a video consultation. But for things like musculoskeletal conditions, or if someone has a deep vein thrombosis, which is a blood clot in the leg, you can quite clearly at least point towards a diagnosis by seeing someone over a video call. The other benefit of having a video call is sometimes it allows you to see someone in their own home environment. And one of the beauties of general practice was being able to go and having your family doctor come and visit you at home. Unfortunately, due to the pressures that we're under, it's not something that we have the capacity to do. I feel really bad sometimes on a Friday when I say to a patient, I don't know physically how I can get out to you. I've got 20 people on my list. There's no way I'm going to be able to come out and see you today. So I'll arrange you a visit tomorrow. And in the meantime, this is what I'll do. That for me is not really the ideal way of delivering healthcare, but it's the reality that we're in. And so if I can sometimes do a video call to see someone in their home environment and get a feel for how they're coping, that can be a good starting point for that conversation. Similarly, some of that conversation can be asynchronous. So when I log into my computer on a weekly basis, I get a widget that pops up called QRX, and that allows me to text the patient and the patient to text me back. And that can be really helpful because it can allow me to ask the patient for photos to help to understand their problem better. It can allow me to actually buy some time. So I might speak to a patient in the morning and say, well, I'll give you an example. I had a patient with who was worried about a stroke and had kind of visual symptoms. And I said to the patient, well, look, you need an urgent assessment of your eyes. So why don't you quickly go down to your local opticians, get an urgent appointment so they can have a look at the back of your eyes, better than I would ever have a look at the back of your eyes with my ophthalmoscope, because they have all this wonderful technology to take a photo of the back of your eye. And I'm going to send you an open text message to say, what was the outcome? Did they find anything worrying? Or actually, might there be something else going on? And the patient came back and said, no, I went to the opticians, everything was fine. So I said, okay, well, now I need to see you face to face to think about what other symptoms or what other causes there might be for the symptoms that you're describing, because I've ruled out a physical cause in the eye. So it allows you to stay communicative with patients in a really interesting way. And I think that's why asynchronous consultation tools can be really helpful. Connections between clinicians are really important as well. So being able to, and this is not something we do a lot, to be honest, in the NHS, maybe it's something we need to think about, is virtual consultations between a clinician from one space to the other. But you were describing earlier the role of a surgeon, for example, in Dubai is able to see what's happening in a theatre in Houston. One of my colleagues, Shafi Ahmed, who leads on kind of the role of extended reality technologies, was one of the first people to do a surgery with a Google Glass on, and that was live streamed on TV. So clearly there are benefits there in terms of supporting from clinician to clinician people remotely. And that can be really helpful in some of the areas where we know we don't quite have the workforce, or we don't quite have the capacity to deliver healthcare in the same way that we might have in certain areas which have kind of a better patient-to-doctor proportion or relationship. The final one is something called e-consult, and the ability to, and I don't mean e-consult the tool, but I mean the ability to asynchronously have an opinion from a from a specialist about an issue, to save a patient time, to support a patient while they're waiting to be seen by a specialist, be able to come up with a management plan so they're not just feeling like they're not unsupported during that time. And that communication tool between yourself and a specialist is really important. The difficulty we have is, so during the pandemic, we saw something called advice and guidance, which was really, really helpful. So instead of sending a patient referral to secondary care, I could send information to secondary care to a specialist and say, what do you think should happen next? Do you think you need to see the person? Do you think they need some sort of scan? Should I start some certain treatment? And I could open that line of communication and hear back from the clinician within a week to say, this is the best way forward. And therefore, the patient's not waiting for a plan. They've got something in place. Unfortunately, what we found is in certain areas, that pathway just became overloaded. And so what we've seen is we've been removed for certain specialties, which I think is a massive shame, because it allows people to not feel like they're waiting 6 months, 1 year, 2 years to see a specialist. And sometimes it can be up to 2 years, and just feel like they're being left alone and unsupported. So it was interesting to see this from the States, to see kind of the way they set this out in terms of a framework. So focusing more specifically on video consultations and some of the evidence behind what we're seeing, we know that and this was a small, I mean, it's not a massive study. I think it was 270 people overall in the entire study, but they collected some information about what people felt around video consultations. And the majority that did participate in that part of the survey found that it would save time, said it saved travel time, said it saved them costs because they didn't have to travel. And I think that's a really important thing, because when we talk about video consulting, we almost think it creates a digital exclusion, it creates inaccessibility. But actually, in some areas, by doing a video or a telephone consultation, it actually makes healthcare more accessible. So when I was doing something called the Digital Leadership Program, there's a really interesting story there about a homeless person who had never accessed their GP. All of a sudden, when they were able to access their GP remotely, it's something they did because they felt less stigmatized going into the practice. They felt that actually having that distance to be able to connect with their GP made them feel more comfortable in accessing the care. And that's really important to consider, that sometimes some patients can't afford to come into the practice. They can't afford to see you face to face, or they just don't have the ability to do that, or they feel stigmatized by doing that, by sitting there waiting in the room. So that if you can deliver a consultation remotely, you might be actually increasing accessibility for certain individuals. We talked about not spreading germs in the waiting room. I mean, it's wonderful to see a slightly clear waiting room, because from a public health point of view, it absolutely is safer to have people not sitting next to each other who are unwell in a waiting room. And it absolutely is important that patients are not waiting 20, 30, 40, 50, 60 minutes to see me in my practice. And it's very rare now that actually a patient waits more than 10 minutes to see me. Whereas before the pandemic, people would wait 20, 30 minutes because I'd be overrunning. Now I know, because not my whole clinic isn't face-to-face, actually I know when my face-to-face patients are on my list, and they'll be prioritized because I know they're sitting there waiting in the room, whereas the person I'm going to be calling, doesn't need to necessarily have to be at that time. And I will try again, but there is a factor there in terms of when we miss them and what issues that causes. Faster access to the GP than waiting for a normal appointment. I think this is entirely true. If you're producing an opportunity to speak to a GP over the phone, you can actually see patients in a much more quicker or efficient way. But also, when people are doing consultations at a distance, you can also triage patients in a more effective way as well. And not needing to take time off work is really important. I work in a practice that supports multiple professionals or working professionals in terms of our patient population, or a large part of our patient population. And for them, it's really helpful to be able to continue working. I do sometimes call and catch people on a Teams meeting and say, "Oh, I'm really sorry, I need to just leave my Teams meeting very quickly." But that's the reality of the world that we're in. And so there was a really interesting piece from the University of Oxford and their Nuffield Department of Primary Care Health Services that just offered some views on this, and essentially came to three core areas: greater accessibility for some, but also problems of access for others. So one of the challenges that we had during the COVID-19 is a lot of secondary care specialties wanted a photo of a skin rash, for example, in dermatology, to be able to refer a patient, but not everyone was able to take a photo on their smartphone device. And that, you really have to do an assessment of whether you feel someone is able to do that and send it back to you. Because it's not necessarily one, there's a challenge of, do you have the right device to take a photo? Two, there's the challenge of, are you able to access the link to be able to send the photo back? There are multiple steps in that process, and so it's important to really understand what people are capable of. And we can't create a pathway where only certain people can access care, because because you say, well, if you don't have a photo, they can't be referred. And the advantages of visual connections is really a benefit there to be able to see someone in their home environment, to be able to read their kind of non-verbal communication, feedback. But at the same time, there is a loss of that physical presence. Being able to if someone's upset in your room, to be able to offer them a tissue, to be able to hold someone's hand when they're going through something quite difficult. So there are benefits and also losses to that process. It's about being able to understand which applies and what modality you take. I remember when this all began, it began with the COVID-19 pandemic. I remember thinking, how am I going to do this? How do I develop or deliver a video consultation? What am I looking for? Where should I use telephone over video when I'm trying to understand if someone has a severe COVID-19 episode versus a more mild episode? And this was produced by the British Medical Journal, which was a bit of an overview or kind of a stepwise process of how you might approach the situation. So, making sure you set up what you need, and making sure you have the right equipment available, making sure your connection works for you and the patient, being able to establish, is the patient in a safe place? Are they able to have a safe conversation with you? Are there any challenges there? And being able to produce a quick, rapid assessment of the patient over the phone or over a video call, and focus in on some of the core parts of the history. But then also examine. How do I examine someone at a distance? What am I looking for? I think, is it helpful that they're speaking back to me and then they're talking in full sentences? Yes, it is helpful for me to establish what their breathing is like. But what else can I establish? Is there anything else that I can see? What's the color of the patient? Do they have any blueness or cyanosis or blueness of their, paleness of their skin? What's the general status of the patient? Are they puffing away really, really fast? Those are the sorts of things that you can try and test for. But really interesting, and it's not here because it was taken out, there was a test that was said would be really helpful to do for patients to be able to establish what their breathing status was. And it was something like sitting there and counting the amount of breaths that they're doing in a short period of time. And it was found that actually, no, that holds no value once they actually properly looked at the evidence over time. So it left a guidance by probably midway through the pandemic to say we shouldn't be doing that, we shouldn't be acting on that as a visual factor, because it doesn't give you the right information. And ultimately what you're trying to do is come to a decision, come to an action point and say, what is the best way forward for this patient? So it's quite complex, but during the COVID-19 pandemic, for people that had COVID, it was the only way we could initially do that triage, we could initially see them and make a decision. The other area that I wanted to just do a bit of a deeper dive on was virtual wards. And the reason I've chosen virtual wards is we know it's become a big big story at the moment. It's something that the Prime Minister mentioned a few weeks ago in terms of one of the solutions to be able to deal with the crisis that we have in the NHS in terms of people waiting on ambulances, readmissions into hospital, getting people discharged quicker into their home environments. And so it's a real area that we need to look at in terms of the evidence. And actually, Patrick kindly sent through a really nice evidence review we did at Health Education England, the library team, Library and Knowledge Service that we have there, to be able to look at the current examples of virtual wards and whether they have the right evidence. The reality is that majority, what I said here is the evidence suggests lower mortality, shorter length of stays, lower readmissions and higher patient satisfaction. Having said that, majority of those factors are all built on low to moderate evidence in terms of the quality of evidence scale because of the time that it takes to build really high quality evidence. But it at least gives us a steer in the right direction of where things are headed. The other area that really is important is the economic argument. What's the impact on costs? Is it actually cost effective to be able to do virtual wards? And again, that's something that really has low evidence at the moment. We need to really understand that better and evaluate that better before we throw all our weight behind virtual wards. But regardless, we know that it has a place. And it has a place because we saw it during the COVID-19 pandemic. It really was helpful. Majority of the virtual wards that were set up were to support people with COVID-19 in their home environment, giving people pulse oximeters so they could see their oxygen levels and be able to feed that back to a clinician to be able to decide, do they really need to be in hospital? And when I worked in accident and emergency for the first wave of the pandemic, and really the core question there was, does this patient need oxygen or does this patient not need oxygen? Because that was really the only intervention. In essence, there are medications that you could give, but the only intervention in essence that really truly made a difference, and it was the oxygen. If the patient didn't need oxygen, they were better off at home. And so it's really important to be able to actually collect that information in someone's home environment. And facilitators to virtual wards include good clinical and communication skills, being able to help and understand and navigate the fact that you're at home, but you're receiving care. And making sure that you have the right staff in place to be able to do that, as well as the right regulation and laws to be able to cover you to be able to provide care at a distance. Some of the barriers around it included the lack of patient supervision. So if someone's in hospital, they're of course being monitored 24/7 by a member of nursing staff, and that's not necessarily the case if they're in their home. There's increased burden on whoever's at home with that person. That, whoever the caregiver is for that person has an increased responsibility, and there's more difficulty sometimes in conveying the right information back to the clinician, and sometimes it can have a more increased effect on staff, because you need staff to be able to travel out and access the patients and support the patients in terms of collecting information. You need someone back in the base area to be able to collect that information and make decisions. And sometimes, rather than actually saving workforce, it can increase in the workforce needed. There was a really interesting piece of work that was done to look at community nurses that were supporting people in a patient home and what some of the challenges that they come under when they were doing that. And the key factor there was connectivity. Having poor connectivity in a patient's home meant they actually weren't able to feed back information. They weren't able to do what they were trying to do. They couldn't access their healthcare record in that home environment. So they'd have, and actually that's true. Even when I go and do a home visit, I have to write on paper and then go back into the practice to be able to write into the patient notes, because I can't access my healthcare records at a distance. I can only access it from my practice room. So that's clearly a challenge as well. Many found it difficult to use the device, to be able to feed back information. The tablet or the iPad, we have to recognize that just as digital literacy is a factor for society, it is a factor for our workforce as well. We need to support people with accessibility to devices, to mobile devices, etc. Interoperability of tools is a big problem as well, being able to talk to each other. So if you're inputting it into one system, does it talk to another system? Does the ambulance service know, for example, that I've seen that patient today and I've said, actually, I think they're okay in their home environment, and this is the management plan? Or does the ambulance service know that this person has a do not resuscitate order? These are some of the challenges that we have in terms of sharing that information. And so it's really coming back to, as we move towards virtual healthcare, we recognize that majority of the population has connectivity and online, but still a quarter of the population have low capability to be able to use those digital tools. And this is something that's produced every year by Lloyd's in terms of their sort of digital index. And the reason they do it is for banking. We all do online banking. More and more banks are shutting down in terms of their physical presence. And the reality is that works for some, but there will be a portion of the population that you are excluding from managing their finances, and the same will apply for health. And it's important I don't think that's a barrier to doing this. I think it's important that we consider what the pathways and the impact are on those individuals and how we make sure we safeguard their access to healthcare. And the other big factor I think to consider is sustainability and the impact on the climate. So this is something that's still being kind of worked, but I think it's something like 3 kg of CO2 is saved per each digital appointment. There clearly is a climate impact or positive impact on the climate from doing virtual consulting. At the same time, the types of servers and the tools you need to be able to do virtual consulting or hold virtual healthcare records also will have a climate impact. So we have to do some more work to really understand this problem. Is this something that's going to help us from a long-term sustainability point of view? And at the moment, some of the evidence suggests it does, but I think we need to be more lateral in that understanding. And I wouldn't be here today if I didn't spend some time talking about skills and capabilities. I'm really proud because today we published something called the AI and Digital Healthcare Technologies Capability Framework. And this was really my mission when I first joined or rejoined Health Education England, to kind of think about how we prepare for digital AI and robotic technologies in the future, is reflecting on the fact that as a GP, when I went back into practice after working in accident emergency, and I had all these tools that were I had to use, I didn't feel like I was in the best place to be able to use those tools to provide the best patient care. And so what could have been done differently? What did I need to know or learn to be able to do that? And I'm really proud that we now have a framework in place that actually says, this is what we need in terms of digital health for patients in the public. This is what healthcare professionals need to know and understand to be able to work with some of these tools. Similarly, more specifically for providing direct care with those digital technologies. So thinking about some of those tools that I've described today and what those skills are going to be in those areas. And finally, focusing and homing in on that remote consultation. So when I'm doing a remote consultation with someone, what are the factors that I need to consider? What are the frameworks that I need to use to deliver a safe, effective remote consultation? What do I need to understand in terms of where the limitations lie when I want to then say, well, actually, this is where the remote consultation stops, and this is where I need to bring you in physically into the room or need to visit you in your home environment. And being able to really put this out in writing to support individual learners out there to be able, who are working in the NHS, to be able to understand where their limitations lie and what their understanding needs to be of these technologies, I think is going to be really important as we go forward and continue to expand in this area. So thank you for listening. I hope that was a bit of a whistle-stop tour of kind of where we are in this space and kind of my own personal reflections on where we're going. And I look forward to having a conversation.